Hello everyone, welcome to NG's Corner for Nurses. Hope all of you are doing well. In last two videos, we have covered the concept of water seal drainage along with related anatomy and physiology and also the purposes, indication and principles of water seal drainage and then the different sizes of chest tubes and the site of drainage tube insertion and also the functions and the types of water seal drainage system including the analog multi-chamber system and dry suction drainage system. Let's see today's video. In this video, we will cover the nursing responsibilities regarding water seal drainage, then the criteria for removal of chest drain and the key roles during removal of chest drain. Let's discuss the nursing responsibilities regarding water seal drainage. First is monitor the vital signs, breath sounds, oxygen saturation, the insertion site, pain and intake output. Assess the chest tube dressing in every shift for oozing or any discharge or for surgical emphysema and change the dressing at every 24 to 48 hours as per the instruction and record the date and time of the last dressing change directly on the dressing. Assess the drainage output from the chest tube. Note the color and the amount every 8 hourly. Assess the tube is free from kinks to maintain the patency for free draining. Next is secure the chest tube to the drainage system to reduce the risk of failure of an airtight system or to prevent air leakage. Next is coil excess tubing on the mattress next to the patient because it prevents pressure of tubing on the suture side and avoid unnecessary discomfort of the patient. Then ensure that the chest tube is never milked or stripped to maintain patency because milking can cause an increase of pressure which can cause damage to the lung tissue and vasculature. And the next is chest drainage system should be upright and below the level of insertion so that the system can function effectively because the system is functions on gravity, that is the flow from higher level to lower level. Make sure the water seal chamber is filled with sterile water to the level specified by the manufacturer to prevent air entry into the interpleural space. Next, ensure drainage tube in water seal 2 to 2.5 centimeter below the water level. If the tube is not deep enough, there is a chance of air entry from the bottle to intrapleural space. That's why we have to ensure the drainage tube in the water seal should be 2 to 2.5 centimeter below the water level. Next is establish original level of fluid by marking with pen or tape because it provides a baseline for the measurement of fluid drainage. Then next is assess fluctuation or tidling of the fluid level in the water seal chamber because we already learned before that fluid rises on inspiration and falls with expiration, indicating the proper function of the system. Ensure that the suction control chamber is filled with sterile water to the 20 centimeter level or as prescribed because suction pressure depends on the depth of the water in the suction chamber. If using suction, make sure the suction unit's pressure level causes slow but steady bubbling in the suction control chamber because it denotes the proper functioning of the system. Look for constant or intermittent bubbling in the water seal chamber which indicates leak in the drainage system. Maintain a high Fowler's or semi-Fowler's position to the patient because it permits optimal drainage of air or fluid and ensures maximum drainage of air or fluid by gravity. Next, ensure that two tubing clamps are always at patient's bedside to minimize the risk of the patient in case of accidental disconnection of drainage tube. And also, these clamps are used during the changing of the drainage bottle. Next, ensure that the bottle of sterile water or saline is at the client's bedside to refill the water seal and suction chamber as needed. Encourage the patient to perform deep breathing, coughing and incentive spirometry because it facilitates the drainage process and re-expansion of lung. Next, assist with repositioning or ambulation as ordered by the physician. Next, coming to the criteria for chest tube removal. Improved respiratory status. How we will understand the respiratory status is improved? There is no labored respiration, decreased use of accessory muscles, respiratory rate less than 24 breaths per minute and equal breath sound in both lungs. Next, drainage reduced to 50 to 100 ml in 24 hours, no air leakage, absence of fluctuations in water seal drainage and expanded lungs as shown on chest x-ray. Next, coming to the key roles which we have to maintain during removal of chest drain. First is to assess criteria for chest tube removal which we have already discussed in previous slide. Next, during the chest tube removal, instruct the patient to hold the breath and the tube should be quickly removed and suturing done in a fraction of seconds to prevent occurrence of pneumothorax. Once the tube is removed, the dressing is applied. Check that the dressing is secure and airtight. This dressing is done to reduce the post-chest tube removal complication of pneumothorax and the dressing should not be removed for 24 hours. Check the post-chest tube removal X-ray to determine whether a pneumothorax is present on chest tube removal. Then assess the client in 30 minutes for rapid heart rate, decreased breath sound, increased shortness of breath, decreased oxygen saturation or chest pain or pain with inspiration to ensure early recognition of post-chest tube removal pneumothorax. We can conclude the topic of water seal drainage with some special points which we have to remember. First one, the depth of the water in the suction bottle or suction chamber determines the amount of negative pressure that can be transmitted to the chest, not the reading on the vacuum regulator. Second one, in gravity drainage without suction, the level of water in the water seal chamber equals to intrathoracic pressure. And the third one is when we apply suction, level of water in suction control chamber plus level of water in water seal chamber equals to intrathoracic pressure. These are the references. If this video is useful for you, then it is requested to put a like and share it with others. And for getting more videos like this, you can subscribe my YouTube channel or follow my Facebook page NG's Corner for Nurses. And for any queries or suggestions, you are most welcome to comment. Thank you for listening.